So today we're going to talk about the mechanisms of blood pressure, and this is a slide diagram that I drew, but as we go, it'll make more sense to you guys. So first thing, when we talk about blood pressure, usually what is blood pressure and why is it important to maintain our blood pressure? So usually, we have this equation is something called your blood pressure is equal to what? Your blood pressure is equal to your cardiac output times your TPR, right? That's what it is. So blood pressure is equal to cardiac output times TPR. But blood pressure, what does that really mean? Blood pressure usually, when we talk about blood pressure, we also talk about this cardiac output, right? And the cardiac output is, what is cardiac output itself is, what does cardiac output means? Cardiac output basically means that stroke volume times heart rate, right? So the ventricle is pumping blood. Each ventricle is pumping out the blood per unit time. That's what stroke volume means. And then cardiac output is directly proportional to your stroke volume, because if you increase your stroke volume, you increase your cardiac output. If you increase your heart rate, you also increase your cardiac output, right? And this stroke volume itself is dependent on what? Itself is dependent on your end-diastolic volume, right? End-diastolic volume, right? Or blood volume. And this, because if end-diastolic volume is more, then you're going to have an increase in stroke volume. And what about the stroke volume itself is dependent on what? A couple of things, right? We have to talk about venous return. Because if you have an increase in venous return, right? I mean, we could simplify this one, and we can say actually, a right atrial pressure, we can say that, right? Because if your right atrial pressure is low, then we'll have increase in venous return. And if you increase in venous return, you'll have increase in end-diastolic volume. And if you have increase in end-diastolic volume, you increase in stroke volume, you increase in stroke volume, you increase in blood pressure. Okay? That's what it is. And so as your heart rate, what is heart rate? If you increase your heart rate, you increase your cardiac output, right? How does that make sense? Because remember, if you increase your heart rate within the physiological limits, what happens is we're talking about the ventricular filling times, okay? But sometimes what happens is that if you increase your heart rate, there's one exception though. If you increase your heart rate beyond the physiological limits, okay? If your heart rate is too much increase, then what happens is that your ventricle filling times, so let's just make this, your ventricle filling time decreases. Okay, your filling time decreases. And if that case happens, then your ventricle is not getting enough time to fill the fill. So that way you'll have a decrease in cardiac output though. Okay? And that time your blood pressure will go down. Okay, let me repeat one more time. If your heart rate increases more than physiological limits, okay? Then what happens is that your ventricular time, the ventricular filling time, that decreases. And the ventricular filling time decreases, then what happens? Then your ventricle does not have enough time to fill the blood in the ventricles. So because of that, cardiac output would decrease, and that in that case, your blood pressure would go down. Okay? But that's the exception. But right now, within the physiological limits, if your heart rate increases, you increase your blood pressure. Okay? That's what it is. And then TPR itself depends on your arterial load, right? Arterial load, because if you have too much resistance, then what's going to happen? If you have too much resistance over the aorta side here, right here, what happens is going to be, you're going to have increase in blood pressure, or TPR is also directly proportional to, TPR usually belongs to diastolic pressure. Right? And the cardiac output usually for systolic pressure, because what happens? Systolic, because the cardiac output, which basically means is that when the ventricle is contracting, what happens with this? From here, obviously this mitral valve is closed, and then whenever the ventricle is contracting, it can go up to like 120, okay? And that is your cardiac output, right? And that represents your systolic pressures. And then when the blood is coming down here, really what happens here is that whenever these arterioles, okay, they have the circular smooth muscle cells, right? And because they don't have elastin properties as well, and these guys are usually tonically contracted, and whenever the pressure comes, because of this, they provide resistance. So whenever the ventricle relaxing this aorta, remember when the blood comes in, aorta got distended, right? And later when it started, when aorta started equaling, it's sending the blood into it, and these arterioles is working as a resistance, right? Because of that, when the ventricle is relaxing and this aorta is like recalling the blood in, these guys have provided resistance. So when you add all the resistance, we call them the total peripheral resistance, and that gives you diastolic pressure, right? Now what else is this thing? Now, if I could say this, right, if blood pressure, I can rearrange these equations, and usually, let's say cardiac output is equal to systolic pressure, and I said TPR is diastolic pressure, right? That means we know this. If we know our systolic and diastolic pressure, I can find my mean atrial pressure, right? What is mean atrial pressure? Mean atrial pressure basically means whatever my cardiac output is, whatever my systolic pressure is, like one third of my systolic pressure, right? Plus diastolic pressure, and if I do that, 130 over 120 plus my diastolic was 80, so that should give me 40 plus 80 is like 93 millimeters of mercury. That is my diastolic pressure. In this pressure, what is happening here is that the flow from this oxygenated blood is carrying from the left ventricle, it going to all of my tissues. But this is mean arterial pressure. Guys, do not get confused the mean arterial pressure with mean systemic pressure. Okay, because mean systemic pressure, which basically means is that when, let's say, this heart is not contracting, okay, when this heart is not contracting, let's say this is a failed heart. When there's a failed heart, whatever volume of the blood is in all these blood vessels, okay, that represents your mean systemic pressure, okay, or you can simply say that mean systemic pressure is that pressure that is actually, and usually it's about very less, it's about like 6 to 8 millimeters of mercury. Okay, and this is representing the pressure that is going to bring from the tissue to your right heart. Okay, this mean arterial pressure is bringing pressure from the heart to the tissue. Okay, that's mean arterial pressure. Mean systemic pressure is from the tissue to the heart. That is mean systemic pressure, and which usually it's very, very low. Okay, now I just wanted to make this very, very clear to you guys before we go very, very detailed on this information. Now let me quickly say. Now we know that. So now then I could just simply mean arterial pressure. I could just say this then. I could just simply say that mean arterial pressure is equal to cardiac output times TPR. I could just say that. Or if I want to rearrange this equation, I could just say cardiac output is equal to mean arterial pressure times TPR. Right? Look, what happens? If I increase my cardiac output, I'm increasing my mean arterial pressure, right? It makes sense because I'm talking about systolic pressure. If I increase my TPR, what is happening? If I increase my TPR, total peripheral resistance, I'm going to decrease my cardiac output. And it makes sense, right, guys? Because whenever there's a high cardiac output, whenever we're talking about cardiac output, we're also talking about the flow, right? Whenever you have increase in cardiac output, you want to have certain resistance, so that way the flow doesn't go very fast. Okay, let me just use another equation here. I can simply say, I can say, okay, Q is equal to, right? This is my flow, which is going to be velocity over area, I can say, right? So that means my flow, okay, I'm talking about one thing. If my flow is directly proportional to my velocity and over my area, or I could just simply make this equation to convert into Q is equal to delta P, right? I could just say that, and then I could just say resistance, right? My flow, if I have increased pressure, I'm going to have increased flow, right? But my flow is directly inversely proportional to my resistance, because if I have increased flow, I'm going to have increased velocity, and I want, like, look, when the flow comes in the capillaries, we want to have a better gas exchange. So if there's a the flow is very fast, the velocity is slow, then I'm not going to have a good exchange, right? So that's why I need to have some resistance, right? Now, I can also rearrange these equations, and I can use this guy named the I don't know how to spell name, Poisseville equation or something like that. Poisseville equations, which basically says is equal to, look, he says what he says. He said resistance is equal to 8 NL over pi R4. He also says that, right? And he's talking about the diameters of, because remember, what did he say? If you decrease the radius by the power 4th, okay, you're going to have increase in resistance, right? And this is a viscosity and length. And we can arrange these equations, and I can even put this as a flow equations. So I can put this one, and I can say Q is equal to, my flow is equal to my delta P, right? Then I can say pi R4 over 8NL. I can say that. Which basically means whenever I have pressure, I have increase in flow, right? So if my radius is directly proportional to my flow, because remember, if I increase my radius, right, I'm going to have a increase in flow. But if I decrease my radius, I'm going to have a decrease in flow. That's what it is. And I can simply, and then if I just add all the, because remember, this is supplying the system circulations, then system circulation. So if I just simply, the flow I can use, because the flow is whatever left ventricle is pumping out, right? So I can use these equations, and I can just directly, I can just say cardiac output, right? Cardiac output is equal to what? I could just cardiac output, I can say cardiac output is equal to delta B over my, right? Delta B, R4 over 8NL. I can also say that too, right? So there are a lot of equations I can use this, guys. Okay, but one thing that I want you guys to remember is this equations. Okay, I'm gonna erase all these, and I want you guys to remember this equations. A couple of equations that I want you guys to remember this. Okay, one equations I want you to remember is my BP. I'm gonna actually write it down in the middle here. Okay, I'm gonna write this down as here. Mean atrial pressure is equal to, okay, my cardiac output times TPR. I want you guys to remember this. And mean arterial pressure is the same as, because of your blood pressure. Okay? You have to remember this, because guys, the reason why we're talking about the blood pressure is we're trying to maintain the mean arterial pressure. Okay? Because this is the pressure we're maintaining that is going to send the flow to all part of the tissue. So that's why we need to maintain this mean arterial pressure, right? And because we're talking about systolic and diastolic pressure here. So mean arterial pressure tells us about the perfusion pressure. Okay, it's a perfusion pressure of all the systemic organs. That's what it tells us, right? And whenever there's a fluctuations on the mean arterial pressure, you will have your system is so good that it can able to maintain. For example, like there's a graph. It shows something like if it's anything that's from 50 to like 180, actually it's like 60 to 180 millimeters of mercury, what happens is like it will able to maintain, and this is like a pressure, okay, from 60 to like 180 millimeters of mercury. What happens is that whenever you get up suddenly, like let's say you're in supine position like this, right? And suddenly when you walk up, suddenly you get up, what happens? All the blood actually pulls to the peripheral, right? It goes to the legs. That time, what happens is that there's a mean arterial pressure obviously drops, correct? In that case, what happens is that you have mechanisms. It's your mechanisms from your brain. They increase your what? They activate your sympathetic outflow, and they'll try to increase the contractility of your heart. So that way you don't go through process of syncope, or you don't have fainting. Okay, and that's why your mechanisms, your rapid changes will happen all the time. Whenever there's a fluctuation in mean arterial pressure, your body, your neuronal mechanisms, or your arterioles, and endothelium derived factors, they're playing a role into maintaining this mean arterial pressure. Okay, this is very, very important, guys. So this is very, very important concept. You have to remember these equations really well. And I'm going to put one more equation down here, okay? My TPR is equal to, my TPR is equal to what? It's 8NL over pi R4. I could just say that, right? And the cardiac output itself is dependent stroke volumes times heart rate, and also in the venous return. Okay? And as we go, we'll talk more about this, how this process is gonna take place, all right? Now, I'm gonna erase this part. Okay? Now let's talk about it. Now, today, what I'm gonna do is the blood pressure. When we talk blood pressure has two mechanisms to our body regulates it. Okay? The one way is that the mechanisms of regulating blood pressure. Okay? The mechanisms of regulating blood pressure. One is called we call short term. Okay, and other one is called long term. So what does this mean? Basically, short term means rapid changes. It happens rapidly. Rapid changes, okay? And then there are a couple of things in the rapid changes that happens, okay? And this has to work very fast. One is going to be, okay, neuronal control. Neurological control. Let's go with that. Neurological controls. Okay, and we'll talk about what does that mean. And we have other one is called local controls. And we'll go by what does that mean. Other one is hormonal controls. Hormonal controls, okay? This is what is going to regulate your blood pressure. And whenever we talk about long term, we talk about, okay? Whenever we talk about long term, we talk about the blood volumes, okay? This is where you're trying to maintain the blood volume, okay? And usually for this one, we usually include renin, okay? Angiotensinogen, okay? Aldosterone system. And we'll talk about what does that mean. Sorry for spelling, but that's what it is. And whenever we talk about like rapid changes and all that stuff, there are a couple of things we have to learn. Whenever we talk about things, we have to talk about this is where we talk about like, the contractibility of your heart, okay? What's going to happen with the diameters of the blood vessels, okay? And then we're also going to talk about what's going to happen to the heart rate, okay? This is all comes in the contractibility, heart rate, diameters of how the change in the diameter plays a role in maintaining your mean arterial pressures, and also how does the heart rate play a role in maintaining your blood pressure. This is what we're going to talk about it right now, okay? So now let's take a case, okay? Let's discuss about this person has hypotension. And what is hypotension is? Hypotension, we're going to talk about hypotension first, okay? Hypotension. This is a decrease in blood pressure, right? And usually what happens is that, this is our case, guys. Hypertension, we'll talk in the next class. Hypotension basically means that what happening? A couple of things. Hypertension, lower blood pressure, right? That means your systolic pressure is probably going to fall less than like 100 millimeters of mercury. Okay? So fall. And then what are the causes of the hypotensions? There are multiple causes of hypotension, right? One could be maybe loss of blood volume. Loss of blood volume, right? You could have that. Or you have given like a venodilation. Okay, venodilators, you have given a drugs like that, okay? You have given venodilator, because of that there is a more blood accommodating in your veins. That's why there's a decrease in venous return, and when you have decrease in venous return, you have decrease in cardiac output, right? So that could be that you got hemorrhage. You got hemorrhage, or maybe there is a internal hemorrhage is there, okay? Internal hemorrhage, some kind of shock that could decrease the blood pressure, okay? Like some kind of deep pain, like for example, if you have that's a kidney stone or like gallbladder stone, that could also play a role into decreasing your blood pressure. Right, so, but let's just say for now, there could be many reasons why this person could be hypotension, okay? We'll just say this person has a blood pressure which is less than 100 millimeters of mercury, maybe because of the loss of blood volumes, or maybe you have given venodilators, okay? So because of that, this person has a low blood pressure, okay? Now, whenever you have a low blood pressure, what is going to happen? Okay, look. Now, you got this part, right, guys? Let's go over this. Okay, so now this person has a low blood pressure, right? So, guys, when you have a low blood pressure, what is happening here? When you have a low blood pressure, that means, look, your pressure here is low, right, guys? Your pressure is low. So remember, I said your flow is equal to what? Your delta P over what? Your flow is equal to delta P over resistance, right? That's what it is. So that means if my flow is less, right? If my pressure is low because my blood pressure is low. If my blood pressure is low, the flow is also low, right? And in arterial side, that means a decrease in arterial pressure there is. Okay? There's a decrease in arterial pressure because of maybe a loss of blood volume, right? That's what is happening here. Whenever there's a decrease in blood pressure, what is happening here? When when this is happening here, what happens is that you guys have to know something here. This is left ventricle, this is my aorta, right? And then aorta, we have something called here, this is going to be, remember this, from the arch of aorta at the level of T4 and T5, there is a brachiocephalic trunk, okay, and that divides, there is a brachiocephalic trunk on the right side, which becomes, later it divides and becomes your right common carotid artery, and then from the arch of aorta they are giving left common carotid artery and also left subclavian artery. I'm only showing one artery here, this is representing the left common carotid artery. And what happens to left common carotid arteries? It divides into two. Okay, you're going to have this guy's right here. It's called left internal carotid artery, and this is going to be left external carotid artery. It is also going to happen on the right side also. Okay, right common carotid artery divides into two parts. Okay, right internal carotid artery, right external carotid artery. It's going to be that. Okay, and you see this dilation you guys see down here? This is called carotid sinus, okay? This is called what? It's a carotid sinus. And you see this right down here? This is called body, but these are carotid body. Okay? Look, guys, do not get confused with carotid body with carotid sinus. These are two different things. Your carotid sinus is located more proximal to the internal carotid artery. And this carotid sinus are known as baroreceptors, or they are pressure measuring device. These guys are more proximal to internal carotid artery, but these carotid bodies they have like cells, like a gloma cells, which are very, very sensitive to oxygen level. Low oxygen level, they're very, very sensitive with that, and we'll talk about that too. But right now we're talking about this guy right here. You got to focus into this, okay? This is my carotid sinus, okay? And these are baroreceptors. They are pressure measuring device, okay? But this carotid sinus also are located more down here, okay? Like down here. These are also, let me write down carotid sinus here too, okay? Carotid sinus. They also have carotid body also down here, okay? But do not get confused with carotid body, carotid sinus, guys. Carotid sinus are baroreceptors, okay? And this carotid sinus have like nerve endings actually. These are called free nerve endings, okay? Let me put this carotid sinus and I'll tell you what this means. So what happens is with the carotid sinus, have this, let me make this as carotid sinus right here, okay? When I make this carotid sinus, really what happens, and let me make this as my internal carotid artery, right? So really what happens, they have the channels right here, okay? These are sodium channels actually. And these channels, okay, let's just make this free nerves ending, okay, actually. Free nerves endings, all this, okay? These free nerves endings, okay? These are also called stretch receptor, okay? Stretch receptor, all right? Now, what is happening here? Guys, so what is happening here is that these are stretch receptor and these guys are sodium channels, and these sodium channels obviously they are kind of associated with the microtubules right here, right? They're attached to the microtubules. Okay, all these proteins. Okay, what is happening here? So usually what happens is that whenever the pressure is high, let's say your arterial pressure is high. Whenever the arterial pressure is high, what's going to happen is that whenever the pressure is that pressure, because if you have high pressure, remember, okay, I'm going to write this delta P is equal to Q over, what is this, R, right? So whenever there is a high pressure, then there's increasing flow. Your pressure is directly proportional to your flow, right? So whenever you have increase in flow, what is going to happen? So whenever you have increase in flow, what is going to happen? That means the flow is going to start hitting the wall, right? The flow. And because of the flow, because of pressure, what happens is there will be stretch on this free nerve endings. Whenever there's stretch on the free nerve endings, what happens? Remember, extracellular fluid is rich in sodium. Sodium will rapidly go in. Okay? Rapidly sodium will go inside. When the sodium will rapidly go in, what happens? If I make these cells, it will bring threshold right away and the depolarization will happen. When the depolarization happens, what happens? Action potentials occur, right? Action potentials occur, right? That means the firing of this frequency of this impulse that's going to fire will be amplified. It will be much more faster, okay? Because of the rapid influx of sodiums from the extra fluid to inside this one, right? Because these are sensing. So because of that, because the cytoskeleton, they got stretched, more ions got in, sodium got in, right? Because of that, the frequency of action potential increases, okay? Because of that, and when the frequency of this increases, what happens? There's nerves actually. These nerves are called herring nerves. These are part of glossopharyngeal nerves. Okay, let me make these herring nerves. These are called what nerves? let me write it down, H-E-R-I-N-G, herring nerves, okay? These comes and join with, because the herring nerves are part of glossopharyngeal nerve, okay? And they will come, which is a cranial number 9, right? And this is going to bring the afferent signals, because it's firing afferent signals to our nucleus down here, guys. And that nucleus is going to be, I'm going to talk about that, okay? That's the beauty of it, okay? That's what it's going to happen in generally, okay? But now, remember, guys, we're talking about hypotension today. So that means what's going to happen here is, we're not going to get the pressure because it's not going to hit the wall here. What's going to happen is that because remember, they always have to get certain action potential is always constantly happening down there, right? But whenever this carotid sinus, so that's aortic sinus, really what happens, whenever they sense it, right, there's not much a stretch on this receptor, okay? Whenever there's not much a stretch on the receptor, they will consider that as the pressure being low, the blood flow, the volume of blood being low, okay? Because of that, the pressure being, they will send that electrical impulses saying that, there's not much firing is going on. And with the herring nerves, and then from the herring nerves connecting with the glossopharyngeal nerve, it's going to report to the big boss here, okay? And we'll talk about who's in charge of controlling this blood pressure, okay? Now we'll talk about this. Now we'll go. And same thing is happening with the aortic sinus here too, okay? Because they both are sensing the pressure being low here. So whenever they're sensing the pressure being low, or they're not getting stretched and sodium is not going much into and causing the action potential to fire, what is going to happen is this guy will sense something else. And with this, what's going to happen is from there nerves is coming, okay? And remember, these guys, I said these nerves are what? The herring nerves, okay, coming from here. And then from here, it'll go down here, and these are afferent, okay? And guys, these are also called buffering nerves. The reason why they are called buffering nerves, they buffer the blood pressure, right? That's why these are also called buffering nerves. And this is going to be my cranial number 9, which is my glossopharyngeal number 9. And from the aortic sinus right here, okay, they are coming down here, okay? And this nerve is what, guys? This is going to be, and also getting afferent signals, and make it right here, okay? Make it here. Connected. And then this is going to be my vagus nerve, which is going to be my cranial number 10. Okay? Now you guys got that so far, right? Now we are here. Okay? Now there is this nucleus and the medulla, actually. Obviously, there are bilaterally this nucleus present, but I'm going to only draw one more, okay? I'm going to draw. This is the main regulators of our blood pressure, okay? Because this guy modulates, this makes the decisions. And what is this guy? I'm going to make it in the middle here, okay? This is going to be my big guy, okay? And then he has, okay, making with this, okay? And then this has two, look, we'll make this guy. All right, okay, now this is going to be what? This is located in the medulla, okay? This is called nucleus, N-U-C-L-E, nucleus of tractus solitratus. Okay, this is what nucleus of solitratus. So this is it's going to, from both cranial number 9 and 10, which is a sensory. Okay, because bringing from the peripheral, they're bringing this and telling this guy that there's a decrease in blood pressure. Okay, now when they get this guy sense it, he's gonna do a couple of things. Okay, there are in the nucleus present here. There are a couple of things are there. Okay, I'm gonna make. Okay, let me make this a little smaller so we can make this a little beautiful here. Make it down here. Okay. Okay, so there are a couple of nuclear centers here, okay? They're located in the medulla, right? Okay, one is going to be let me write down here. This is going to be cardiac inhibitory center, okay? Cardiac inhibitory centers, okay? Actually, oh yeah, this is fine, red is good. And then, actually, let me make it in a different color. This guy, let me make it in black. No, actually, let me make it green. So this is going to be my cardiac inhibitory center right here. Or we can also call cardiac deacceleratory centers. And then there's one more nuclei here. right here, let me write it. This is called cardiac axillary center. And then there is one more nuclei here. I'm going to write, and it's called vasomotor center, okay? And vasomotor center has two parts actually. One is called vasoconstriction area and one is called vasodilator area, okay? And this vasoconstrictor area, I'm going to write down vasoconstrictor as a VC, okay, right here. And the reason I'm putting it, it's actually located in, I'm going to write down it. It's going to located in upper medulla, which is we call the rostral, okay? Rostral, okay? It's located anteriorly, okay? So we call them the rostral ventral lateral medulla. That's what located. And other one is, let me write down the vasodilator, okay? And this guy is located in the lower, okay? So that's a caudal. It is also located ventrally and then lateral. So let me just write down caudal, ventral, and laterally on the medulla it's located. That's what we call them a CVLM also, okay? That's what it is. Now, these are the different nuclei here, okay? But your main nucleus are going to be cardiac inhibitory centers, cardiac axillary center, and vasomotor center. And vasomotor center, based on what we're trying to do here, it will kind of sort of like modulates this area and decision. Because when you talk about look, if you use a vasoconstriction, right, you're going to constrict it. If you're going to vasodilate, it's going to vasodilate it. That's what it does, okay? And based on whether we're trying to increase the blood pressure or trying to decrease the blood pressure, that's how this will play a role into it, right? Now, because right now our goal is what? Try to increase the blood pressure, right? Because this person has hypotension, correct? Now, what is going to happen? Now what is going to happen is this is where you have to understand really well, okay? Now, if we're trying to increase the blood pressure, right, what do we do? We need to somehow inhibit this cardiac inhibitor center. Because remember, cardiac inhibitor center, what is it doing? It is releasing vagus. Because this cardiac inhibitor center is actually connected with the dorsal, vagus nuclei, okay? Because of that, it's connected with the dorsal vagus nuclei. Let me make this. This is my vagus nuclei, okay? Because it's connected with the dorsal vagus nuclei, obviously, it's going to release acetylcholine, right? And do you want the acetylcholine to be produced right now? No, we don't want that because remember, we don't want to decrease the blood pressure. We want to increase the blood pressure right now, right? So what this solid tractor nuclei does is it will inhibit cardiac inhibitory centers. So when you inhibit cardiac inhibitory center, what happens? These guys will no longer actually supplying to the acidoidal cells, AV nodal cells, and it will not able to send the fibers to the atrial myocardium either. Remember, vagus nerve does not have any receptors in your ventricular myocardium. That's exception because this is we're talking about the parasympathetic. Okay, now, but what does this guys do? But what these guys will do is that we'll come back to this one. But it will stimulate cardiac axillary center, and it will stimulate. What is this guy? Vasomotor center, okay? So now, if you stimulate cardiac axillary center, what is this cardiac axillary center is going to do? Cardiac axillary centers, look, this cardiac axillary center from the descending fibers, I'm making there's a descending, it's always going to come down, okay? It's a descending fibers, obviously this is going to be my white bundle tract, okay? It's going to go to the lateral horn, okay? Lateral horn, okay, because that's where their nucleus are present, okay. From the lateral horn, what is going to happen? From the lateral horn, it's going to give the motor fibers, and from the lateral horn, this guys will come out. And there is going to be, this guy, well, is obviously from the lateral horn. Then after that, the synapse down here, and it will go to something called your cardiac ganglion, right? And then it will come here and it will make a cardiac ganglion. Let's say this is my cardiac ganglions, okay? And these are usually located is level from, let's say, T1 to probably, because they're thoracolumbar, like probably L1 or L2, okay? So they'll come on the lateral, because their ganglions are located in the lateral horn, okay? You're talking about sympathetic. And you'll get preganglion fibers. So this is the preganglion fibers here. And from the synapse at this cardiac ganglions, or your post-sympathetic ganglion, let's say post-sympathetic ganglions, okay, sympathetic ganglions, right? And then it will give up fibers. Now it will give up post-ganglion nerves will go. And remember, right here on the right atria, what is this? There is a SA node, okay, cells. It will gonna give fibers. It will gonna stimulate the SA nodal cells. But how? Because with this cardiac axillary center, this is the sympathetic, these are descending fibers, right? And cardiac axillary center is going to the thoracolumbar, right? So, and going to the sympathetic ganglion. So it's gonna release what? It is gonna release epinephrine. It's gonna release, for this case, we're gonna release norepinephrine, right? Now what is the other thing? Now, it's going to go to my AV node, which is going to be, let's see what is this. This is going to be my cusp, 1, 2, 3, like tricusp. And down here, let's say this is my AV node, okay? It's also given fibers there with the increase this one, correct? Now, SA node. And obviously, this is going to go to Purkinje, and then I'm just going to draw, like for now, we'll just draw ventricle myocardium for now. Okay, and then make this with a red. Okay, now, we'll talk about what they're going to do. What else is going to do? Against cardiac center, because there are two cardiac center, right? It's going to go and make this with the, now let me make this with green. With the post-sympathetic island, it's also going to go to the this is my right side. It's also going to go, okay, actually not. Let's not make this with this. Let's make with the black. It's going to go all the way down. It's going to go here, also on the left part. There's SA node there too. AV node down here, okay? It's going to supply to AV node here. Okay, and also the right here, which is a ventricle myocardium. Okay, look. So beautiful mechanism, right? So what is going to do? So when the sympathetic fiber, and they're releasing what? Norepinephrine. Look guys.